Good afternoon, everybody. All right, nice to see you all. Welcome to Grand Rounds. And today we have a really interesting presentation. Our speaker is Yeon Lee-Tauler, PhD, who is a research assistant professor and senior research scientist at the Uniformed Services University of the Health Sciences. She received her bachelor's degree in public mental health and cultural studies from Hampshire College, and then went on to get a PhD in public health from the Bloomberg School of Public Health at Johns Hopkins University. And one of the motivating factors to get her here for the talk today is she's working with our chair, Ben Lee, on a grant called Cultural Adaptation of Soul Shop with the Korean American Faith Community to Improve Suicide Literacy Among Older Adults. And as a part of that, she's getting a faculty appointment, and we thought it'd be nice to have her here presenting on this work to us. Her presentation, which is entitled Leveraging Faith Communities for Suicide Prevention Research. And at least in my time here, I haven't seen a talk like this, so it'll be novel, I think, for many of us. But before she gets started, let me just say the usual things. If you're on Zoom, your camera and microphone are off by design. Don't use the chat if you're on Zoom. If you have questions or comments, which we hope you do at the end, use the Q&A box. And very importantly, for everybody here or on Zoom, please fill out the evaluation at the end. There'll be a link up there and a QR code, and there should be another email that goes out tomorrow with the link. All right, so now without any further delay, I'd like to introduce Dr. Lee-Tauler, and let's give her a warm welcome.
Thank you all, and thank you, Dr. Silverstein, for your warm introduction. This must be the best psychiatry grand round because you get free food. For those who are on Zoom, you're missing out. So next time you can come in person. Yeah, I am really thankful for this opportunity to share my work in community-based partnership when it comes to suicide prevention research. Rochester holds a special place in my heart, not only because Dr. Lee used to mentor me in graduate school, but also because Rochester has invested in the career development of suicide prevention researchers like me over the years. The last time I came here was 2018 for the research Training Institute in the public health approaches to suicide prevention, thanks to Dr. Eric Kane and Dr. Yates Conwell's leadership. And I learned so much, and I was starstruck having happy hour with suicide prevention gatekeeper training gurus like Dr. Wendy Cross and Dr. Peter Wyman. And I cite many of your works, including Dr. Van Orden's work for my research. So thank you so much for helping me grow in that capacity. For today's talk, this is good. So today's talk, I'll be talking about the rationale for faith community partnership for suicide prevention. And I'll share some works that I've done with the military chaplains when it comes to suicide prevention. As Dr. Silverstein said, I work at the Suicide Care Prevention and Research Initiative with Director Dr. Marjan Holloway and Deputy Director Dr. Jessa LaCroix. And I generally work in the capacity of project leads or co-principal investigators. And also, I would like to share about this upcoming project that we would like to start in the Korean American faith community after taking in all these skills that I've learned by collaborating with military chaplains. Is this still working? The mic is working? Yes? Okay. Okay, keep going. All right. And then I'll wrap us up with a discussion. So the disclaimer here today is that the opinions that I share today are mine alone, and they do not represent that of the Uniformed Services University or the Department of Defense. And the funding support has come from the United States Special Operational Command or the Defense Suicide Prevention Office. So we all are aware of the public health burden of suicide and its related death, like alcohol-related liver disease and drug overdose. And the two Princeton economists, Deaton and Case, have brought those together and called them the death of despair. And initially, these death of despairs are known to affect white men who are less than college educated, but later on, there are more studies showing that diverse racial ethnic groups are affected by these death of despair. And you can see in the early 1900s, the death of despair was pretty high. And from the 1906, there was more of a decline in these type of death with the early establishment of the Food and Drug Administration and the Drug Enforcement Administration. And then in the 1914 and beyond, there was World War I and further decline of these deaths. You can see the increase of these deaths in the 1960s with the counterculture revolution. And since 2000, there has been a rise of these deaths of despair, mostly with the increase of the drug overdose-related death, but also based on the CDC data, we know that there's a statistically significant increase in suicide death between 2000 and 2018. There's a dip in suicide death during COVID, and then there's still an increase of suicide death now. And so some of the scholars have been asking the reason why there's more of these deaths of despair happening in America compared to other wealthy European countries and Japan. Because since 2014, these deaths of despair were bringing down the life expectancy of Americans. And so they go back to the comparison points, as these are anthropologists and neuroscientists. They go back to the comparison point of when we were hunters and gatherers. And back then, you're always a few steps away from death because we're just constantly trying to survive hunger. It takes a lot of effort to kill that wild pig and try to balance that with other priorities like mating and companionship and finding other opportunities. And they really had to rely on their tribe by giving and receiving. And there's not a whole lot of disparities then because everybody was trying to fight hunger. And so fast forward in the modern days, you can just walk into any grocery store to get your bacon. And their life has become more predictable. And so we have fallen prey to the industrial greed, profiting off of our addictive behaviors like drugs, alcohol use. It could also be pornography, gaming, gambling. And these authors go even further to say that our behaviors of wanting sugary products, greasy food. I know many of us, we all have cookies over here. Those are affecting cardiovascular and metabolic disease-related death. And all of these deaths are sharing similar risk factors and affecting similar population who die by these deaths of despair. And so these authors are saying that, especially in the United States compared to other wealthy European countries and Japan, there's more of the disparities. And so between the haves and the have-nots. So if you're a part of that haves group and you have sober parents who are working on raising kids together, and then you have enough savings and investments to pay for high quality preschool education up until college education, which is very expensive. And if you have a stable employer that pays for your vacation, annual leaves and your parental leave, then you're in a better place. But if you don't have that, you're in a much worse place to thrive in America than all these other European countries with better social welfare. So the authors are saying that we should be like the European countries. And so, of course, I would love to have some free vacations, and I want to have extended maternal leaves and, good education for my children. But this is highly political, and I can't count on that right now, that we'll have this level of support from the nation. And so the other scholars are saying that the rise of the death of despair is also coinciding with the decreasing importance of religion in America. And so in the 1970s, 52% of Americans said the religion was very important. Now it's decreased to 45%. 1970s, they're 90% Christian. In 2023, it's 68% Christian. Weekly church attendance has gone down from 40% to 32%. And so this is the religious landscape in America. The largest religious categories is actually this no preference group with no affiliation. They're atheists, agnostics, or spiritual but not religious. Yet, when you look into the Pew Research data, the older you get, and then you look back on your lifetime, the more they report that they've become spiritual. Compared to the younger adults. And it could be that as we age, we have more time to reflect back on our life and also see the losses in your life too, disappointments or death of the loved ones, and seeing more of the reality of death. And in that time, maybe you can appreciate more of the mundane things around you, the natural beauty of this earth, or the social connection and the love that you can share with your family members and friends. Or it could be that you've gone through a lot of difficulties, disappointments, and suffering, and in the midst of it, you realize that you're not defeated. You can actually grow in your character and virtue during those times. So while there is a trend of secularization in America, there are still people, close to half of the Americans, who think that religion is still important, and others who are spiritual but not religious, and they are asking the similar questions on the meaning and purpose in life. So faith leaders can play a role in suicide prevention because they are usually life-affirming. They see life as a gift, and with all the world religions, the sacred texts normalize suffering. And so they see suffering and challenges in life as something that is not a surprise, but something you can persevere through, build your character, and find hope in the unseen, something that are just not from just a day to day. And then you see your life as being meaningful and purposeful in the midst of these challenges because there's an eternal perspective to life. And they try to practice that love and connection and care with each other, the service with each other. So that's the social connection part. And so as faith leaders build that kind of trust and love and relationship with their faith community members, they become natural helpers during times of crisis. They can refer their members to professional care too. And at the aftermath of suicide, faith leaders tend to serve as first responders to loss survivors in holding memorial services or providing grief counseling. Military chaplains are a subgroup of the faith leaders, and so they tend to be commissioned officers within the military systems. They hold master's or doctoral degrees in divinity, theology, or pastoral counseling. And they promote the unit's spiritual and mental fitness. And they might be taking rounds in the unit, checking up on the service members, and trying to see if certain people need more help, and bringing in external resources or a professional kind of care connection. And think about it, service members might be 18-year-olds, newly enlisted. They might not have any background in thinking about religion or suicide, spirituality all their life. But when you come to the military system, chaplains are the ones who are representing that spiritual fitness needs, and that they're saying that resources available, you can come and talk with me. And so the really amazing part of military chaplain, a unique part of military chaplain's role, is that they hold 100% privileged communication. So that's 100% confidentiality in any information service members share with them, whether it's suicidal thoughts or homicidal thoughts, they're legally bound to keep that information. If they share that with anybody, they get into legal trouble. And so think about the military system, just like any other competitive employment environment that is hierarchical and very much performance-driven. That's not usually a place where you talk about your emotional vulnerabilities. People don't want to be labeled as broken, and service members tend to not want to have any diagnosis of mental health written in their medical records. And so those service members who are concerned about potential negative consequences in their career because of the mental health service use tend to access military chaplains. So when we survey military chaplains, they say it's not uncommon for them to counsel service members with suicidal thoughts. So they can be strategic partners for suicide prevention. So there's a complex relationship between religion and suicide risk, as these are complicated constructs with multiple dimensions. The systematic reviews show that it is the behavior of regularly attending religious service, more so than religious affiliation, that is a protective factor to suicide attempts. But you don't see this association for suicidal ideation. So in other words, just because you're attending religious services doesn't mean that it's going to decrease your suicidal thoughts, but it may decrease your suicidal attempts. And since this 2016 systematic review, there was an important paper by Vanderweel and colleagues based on the Nurses' Health Study that weekly religious service attendance among female nurses predicted 84% lower rate of suicide death compared to female nurses who did not attend religious service at all. And so this is a 5-fold decrease in the suicide rate. And it was a rigorous study, longitudinally done from 1996 to 2010. They also adjusted for depressive symptoms and social support. So that is a pretty remarkable finding. And Dr. Harold Koenig, who's a psychiatrist at Duke, who is internationally known for his work in religion, spirituality, and well-being, he said that this study is not surprising, given that attending religious service regularly are known to improve your meaning and purpose in life, a sense of optimism, gratitude, and generosity. And these positive mental health traits or states are also independently connected with better mental health well-being. And so all these together can lower the all-cause mortality. And so there's more and more evidence that is showing this kind of connection. So if your attendance and exposure to faith community can improve these important mental health states, and if the connection with the faith community can decrease those addictive behaviors like drug and alcohol use and gambling, pornography use, then we can really see that how this could reduce not only suicide rate, but all-cause mortality. And even going back to this nurses' health study, it's saying that the nurses who are attending churches weekly have lower substance use, alcohol use, smoking behaviors, and they're more likely to be married. In terms of the applied side that shows a connection between religion and suicide risk, there's much less research done, but we know that religiously tailored cognitive behavior therapy in all like 5 major world religions is just as effective as a conventional CBT when it comes to reducing depressive symptoms and suicidal thoughts, especially for participants with higher baseline internal religiosity. So even though the effects is about the same, it's still important finding because the preference that the patients can have can really affect the way that they would initiate this type of psychotherapy or stay in the psychotherapy. And we also know from a systematic review that mindfulness-based CBT was effective in reducing depressive thoughts and depressive symptoms and suicidal thoughts among patients with depression. So now I'm going to talk about the qualitative study that I led to understand the military chaplains' suicide prevention, intervention, and postvention practices. And this was in preparation for developing a workbook for the suicide prevention intervention for the special operation chaplains. And we made a distinction between prevention, intervention, postvention, because prevention, we refer that as something that would delay the onset of suicide risk or reduce suicide risk, like addressing alcohol use or interpersonal conflicts or suicide-related education. Intervention is when chaplains are directly counseling a service member in suicidal crisis, or referring them to professional care. And postvention is at the aftermath of suicide. How are they responding to their community of those who have lost someone to suicide? And before I begin, I want to give you a little more background on the Special Operation Forces. So they're about 3% of SOF members in the entire military, out of the military personnel. And they usually engage in unconventional operations, like trying to stop terrorist attacks and bringing in more of a peaceful state after an insurgent violence. And maybe some of you are into watching like military or special operation movies like Black Hawk Down. How many of you are into like military movies? Okay, yeah, so some of you are probably more familiar with Special Operation Forces operators' work. There are operator sides who are kind of like going out in small teams on those specialized missions. And then there are also supporters who are working on maintaining the mechanics, or they might be working in a cafeteria. And so they are leading very busy lives, and being deployed in different settings and going into frequent trainings. And military in general, they're quite young. They're in their 20s. Special Operation Forces, they're usually in their 30s with about 2 kids. And I can tell as a parent how a juggling life act it is to try to have a professional life and have my family life, but their lives are much more intensified than what I'm going through as a researcher. And so we also see that within the Special Operation Forces, there's some high risk of suicide. But it's really hard to compare with the conventional service members because the number of Special Operation Forces is so small. It's like 70,000. And so what I did with this as a needs assessment for the workbook was to interview 100 special operation chaplains with our suicide CPR initiative team. And we analyzed 57 interviews until the point of saturation where the coding definitions and coding system wasn't changing. And then we coded the interviews based on suicide prevention, intervention, and postvention topics, and used inductive thematic analysis. And the interview guide questions that we used were really just generally, what are some of the typical situations that you're counseling somebody with suicide risk? What are some of the typical suicide prevention, intervention, and post-prevention strategies you've used? And what are you most or least prepared for? So the chaplains said that foundational to their suicide prevention, intervention, and postvention strategy was building relationship. It is that social engagement, building trust. And so for prevention, nurturing the living, they said that it's really about being available, having that visibility, and going out there in the suck, like doing the physical training together and showing to others that they care for the service members. And also it is about building a community of insiders. And so once you have built trust with a few service members or people in this supervisory position, they would also be the ones monitoring those who are at risk and also sharing resources together. But they also said the challenge of breaking into this tight-knit special operations community, because they're usually a little more skeptical about like quote unquote outsiders, and chaplains are not bearing arms. And so, given that they're having a different role, the special operation forces members might say, who are you? And might not really open up. And when it comes to suicide intervention and caring for the wounded, the military chaplain said that they use the skills of actively listening and responding to suicide risk, like hope building, counseling and talking about coping strategies, and also building autonomy for them to seek professional help. And so even though military chaplains have 100% confidentiality and they can't call anybody when a service member has suicidal thoughts, usually it is that type of relationship that you have built already, that you have trust, and that you can convince and persuade the service member that in your situation, I think it'll be really beneficial for you to seek professional help. And some of them would do just like a test call to the mental health provider or the legal counselor to see what the career consequence really looks like when you do go seek mental health. And so they would guide the service members through that. But sometimes the challenge was that when the service member is not willing to seek professional mental health care, then they would be sitting with the service members at risk of suicide in their office for hours, on the phone for hours, and not fully knowing what exactly to do during those time. And there could be some other suicide intervention skills like safety planning that they could use in the meantime. When it comes to the aftermath of death and responding to that, like honoring the dead, the military chaplain said that they reach out to the lost survivors, whether it is the military colleagues or family members. Some of them had gone to visit the family members who've moved to another state after a service member's suicide death, and also try to connect them to the local faith community. And they would grieve together through memorial services. And really, some of the challenges that they have talked about when it comes to planning for a memorial service is that the leadership might not be very open sometimes to having a memorial service for a suicide death because of their perspectives on suicide. And also there might be some legal implications or family wishes that interfere with the planning for a memorial service. And they also talked about some difficulties on trying to find out the right messaging for the memorial service, not wanting to glorifying suicide, but also honoring the accomplishment and the person that the decedent was. So I'd like to share some quotes from the suicide prevention and some of the sub-themes of building relationship. And first, being available. I keep a bowl of candy on my desk, and I call it my fishing bowl, you know? They will come and say, can I get a piece of candy? And while I'm here, can I talk to you for a minute? I would say in the last 2 or 3 years, the majority is building that relationship, letting them know that it's okay to talk about it, and I'm the person if you feel comfortable to talk. For cultivating a community of insiders, I get the best referrals from people who have a personal relationship with me. I keep going to those events, trying to reach people who are in supervisory type roles and let them get to know me so that when they feel like they have an airman who is struggling, and I'll even get the call sometime, hey, chaplain, can you check on this dude? And I'll accidentally bump into him like, oh, I just happened to be in your area. How's life? What's going on? And try to have a purposeful conversation with them. For suicide intervention and listening and responding to suicide risk, here's a very common scenario. I will have some soldier stop by my office and say, chaplain, shut up and listen, and be just that blunt about it. And specifically, they will say, I don't want to hear anything about religion, just listen. And so I'll kind of sit there for half an hour and they will just blurt out whatever is getting their goat, and I will just bobble my way through it and go on. Help me understand the thought, and I ask a few clarifying questions. Building autonomy to seek professional help. Eventually, I was able to get her to self-disclose. I got her to go to the clinic. She was saying, well, chaplain, will you go with me? Okay, if that's one way you can go, I will go with you. So then she's going to her appointment and she's meeting with the therapist. Well, I just don't know if I want to go. I just don't know if I can go. Would you go with me? And I say, well, I tell you what, I'll go with you if the therapist allows it. And in this case, the therapist allowed it. And the several chaplains have shared that while they tend to refer their service members to mental health service providers, yet they don't get the referrals back to them, or they don't really work together to monitor how they can best help the service member in need. So they said that would be an area that they could improve. When it comes to suicide postvention and reaching out to loss survivors, it's not a cookie cutter what they need, you know? I've had some in response. They just need a shoulder to cry on. They just need somebody to be there, and they don't need you to say anything. Some they just need because I'm a representative of God and they are mad at God. They need somebody to yell at. It's like they're yelling at God. I have been mad. It's being what you need to be when you need to be it. But in order to do that, number one, they have to know you. Grieving together through memorial services, I tell soldiers at memorial ceremonies what a friend he was, what he meant to us, the good times. And then I say this, and we know that our friend here was carrying an invisible rucksack. I know that some of you in this room sometimes carry invisible rucksack. Please, as we remember our friend, help us remember to be kind to each other, to notice if each other are carrying invisible rucksacks, and to help us unpack those things. We have to do this. We're hurting right now. I recognize suicide doesn't mean the person's a coward. They've fallen for the enemy of the soul, and I'm not going to leave him. I'm going to be there, and I'm going to provide the memorial ceremony. So in summary, chaplains saw relationship building as foundational to suicide prevention, intervention, and postvention. And for suicide prevention, there's this ministry of presence and capitalizing on social connection. Yet some of the newer chaplains said that they would need some help trying to have more of the visibility, availability, and the skills for community building, because there's not like a standard operation procedure for that to claim your place in the table, especially when it comes to establishing that relationship with the leadership. When it comes to suicide intervention, they used the skills of eliciting stories leading up to suicide risk, active listening, hope building, and connecting service members to professional care. But some service members were not aware that chaplains had 100% confidentiality, or they would doubt that. And so there's more of that universal education needed on chaplains' privileged communication, and some other skills like safety planning or problem solving could be useful. And there could be more of an intentional team-based mental health and chaplaincy collaboration. At the aftermath of suicide, they did outreach to loss survivors and held memorial services. And yet I think there would be more help needed when it comes to preparing the postvention plan with the command ahead of time before an emergency suicide event happens, so that they know what process to follow, whether to hold a memorial service or not, and if so, how can we hold a memorial service? And then some chaplains talked about the ways to meaningfully involve the affected individuals to the preparation of the service and for the execution of the service, and guiding the messaging of the memorial service will be helpful too when it comes to the balancing, just the messaging, knowing that everybody who's there is not alone, and also there's some care and support available for the loss survivors. So feel free to read more about that in the manuscript, and we also have a Special Operation Forces workbook available too for dissemination. So now I'm going to talk about how we have equipped chaplains to have suicide intervention skills. This really birthed out of a conversation between Navy Chaplain David Bynum, and our director, Dr. Marjan Holloway, and they're having dinner together at some kind of barbecue place. And Chaplain Bynum asked the question of, why can't chaplains be equipped to address suicide needs directly? And the chaplain, Dr. Holloway, being a clinical psychologist, said, okay, let's try to design this. So they started writing it down in a napkin. And so we have other suicide prevention and intervention programs available, as you know, the Applied Suicide Intervention Training Program that's well regarded, and the Question, Persuade, and Refer program too that many of you have used. And so those are great programs. And the military chaplains, what we have found was that they were tailoring these programs for their own needs because they were not really developed for military culture, and it's not tailored for the military chaplains. So we saw that there's a variations of these suicide prevention and intervention programs available in the Department of Defense. And so we saw the opportunity to try to standardize the training that is tailored for the military chaplains. And much of the trainings that are out there, could be cost prohibitive too. And also they focus more on the questioning part, like, do you have thoughts of suicide? And then referring them to professional care. But for military chaplain, that's not always an option. They can end up having more time with the service members without having a professional who can help because of their 100% confidentiality. So what we have done here was to draw from the cognitive behavioral therapy principles to build the chaplain's care training program. And so that's including eliciting suicide story, knowing that a story can have a beginning, a middle, and end, leading up to suicide risk. That gives you a chance to really organize your thoughts and feelings and have connection between the storyteller and a listener, and also have safety planning, knowing that there are certain things you can self-manage, other things you can ask for help, and then ways to put time and distance between you and the lethal means. And then we have a module on problem solving, defining the problem, exploring different solutions, and then acting upon a solution, and then looking back. And then emotional regulation and naming that feeling rather than just like happy or angry. And so that you can have control over that feeling, riding the waves of that emotion, knowing that you will eventually come back to a more calmer state. And then mobilizing social support, whether it is building on existing social support or expanding your social network. And then having more of the adaptive coping strategies, like going out for a run, taking a hot bath, rather than maladaptive strategies like alcohol use. And for hope building too, because you build reasons for living. Many of the suicidal individuals might have ambivalence, and so trying to build more of that hope with the person. And then lastly, because the community chaplains community of interest said that professional burnout is a real issue, we talked about the importance of rest and taking care of yourself, putting the oxygen mask on yourself before you put it on other people. So I'll talk through several versions of chaplain's care. So in 2017 and 2018, we started out with the in-person version of the chaplain's care training program and pilot tested it. So it was a week-long program that military Navy chaplains then came to the Uniformed Services University. We have the Valgy Simulation Center. Rochester has a simulation center too, right? Okay, yeah, and so the chaplains got access to that simulation program that many of the medical students or psychology graduate students also access. And we provided didactics based on those 8 modules that I talked about, and then they had group discussions, some reflection opportunities, and really the biggest part of this program was having simulated encounters with professional actors who are acting as service members with varying risks for suicide. And so we had pre-training simulation encounters. We videotaped them, and we also had post-training simulation encounter and videotape them to assess the pre and post competency measures. And then we also, in between, the chaplains got to replay the pre-training encounters to practice again, because sometimes you go and counsel somebody and you're like, oh, I wish I did a better job on that. So that was their opportunity. After getting more of the didactics, they were able to apply the skills that they have learned in these encounters. And then there are some additional formative encounters that involve new scenarios with practicing the new scenarios with simulated service members. And immediately after those 30-minute encounter sessions, There was a feedback from the chaplain supervisors, mental health professional, and also their chaplain peers. So there's that immediate feedback in addition to behavioral rehearsal. So yeah, that was really good. And then this is a little example of the vignette that we created for these simulation encounters. We interviewed with Navy chaplains and other chaplains to develop some typical situations that they counsel, and also looked into the military suicide statistics and risk factors. And so you can see Eric as a 30-year-old male staff sergeant whose wife had an affair and has been making reckless financial decisions. He's considering divorce. There's some challenges with his relationship with 2 children, and there's more frequent thoughts of suicide, and he's saying, can't speak to anyone about my suicidal thoughts, and my pistol is still an option for me. So we throw a chaplain into a service member who remembered all of these details of Eric, and then let them practice for 30 minutes. So pre and post chaplain's care training, as I said, we videotaped, their interactions, and had blind clinical psychologists who would rate the suicide intervention skills based on the encounter observation form. And so, for instance, this is for the module of safety planning and lethal means counseling. And we would assess whether the chaplains explained the importance of safety planning and assisted them with generating a safety plan, navigating any challenges associated with safety planning, and rate them in the Likert scale. Did they make no attempt, make little attempt, moderate attempt, or skillfully address these items? So there are some pictures. You had a one-way mirror window where the other chaplain supervisors, mental health professionals, and chaplain peers could observe. And at the end of the 30-minute encounter, we had all of them come in to provide immediate feedback. So we had 2 cohorts of Navy chaplains who went through chaplain's care training. We had a happy hour at the end with graduation service, so that was really good. And so we also, in terms of evaluation of the 23 chaplains who went through this, saw a statistical increase in the suicide intervention competency that was rated by clinical psychologists, and increase in the feelings for preparation and efficacy for suicide intervention, and increase in the likelihood of intervening suicidal service members. And some of the specifics here is that out of those 8 modules, the competency that increased was safety planning, problem solving, emotion regulation, coping strategies, and building hope. And the average total score of the competency increased. One of the chaplains sent us an email after the training was over, and he went back to his day-to-day work, and he said, since our training, I've had the opportunity to use bits and pieces of the material that we covered. This morning, however, put quite a bit of it into practice. In the same fashion where we walked into our scenarios with only a short blurb of what to expect, I walked into our main office this morning to find a sailor waiting to speak with me. After seeing the look on his face, the first thought was, my morning schedule just got rearranged. This sailor had planned to take his life this weekend, if not today. He probably would have done so if the person who brought him over hadn't noticed that something wasn't right. 2 hours later, I was able to hand the sailor off to medical for additional treatment. During those 2 hours, though, I relied heavily on the skills you taught us during the care training. Thank you again for time you've put into us chaplains. Thank you for teaching and sharing your expertise with us. Today, you saved a sailor. So while this in-person chaplain's care training was very productive and fruitful, and we were planning to actually go into having a randomized control trial on chaplain's care, we experienced an unexpected congressional budget cut. And so we had to pivot to use the remaining funds to keep the chaplain's care training alive in an online format. And so we took the opportunity to adapt chaplain's care, not just for the Navy chaplains, but also for chaplains in all service branches. And we had about a 2-day of a filming session with 4 real-life chaplains with those actors who are simulating the service members with suicide risk. And they had an unscripted session of just like filming these counseling across these 8 different suicide intervention skills. And so out of that, we massaged those into an online course, adding expert insights, and the mental health professionals will talk about, like how did the chaplain do, and provide more comments. And then we also added some knowledge checks and interactive activities with our e-learning experts. So this ended up being a 6-hour-long online course that we ended up housing in the Military One Source, which is an online site that service members, family members, and the public can freely access any of these online resources. So here's some pictures of Chaplain Charles Vorsogia interacting with our service member, and some pictures of our Chaplain's Care online course. And Eric comes back here with the timeline of his marital conflicts, or even getting married, and today, and for him to tell his suicide story. So at the end of the Chaplain's Care Online, we surveyed about 80 chaplains. Most of them had said that the Chaplain's Care Online was helpful, easy to use, relevant, applicable, and that they will recommend it to other people. And they left some qualitative, like open-ended feedback saying that it would be great to have a workbook because there's a lot of information. I would like to get some summary so that I can remember how to counsel our service members. And they also talked about how we can work a little harder in trying to better integrate the spiritual fitness part of the suicide intervention. And lastly, they said it would be great if we could have some more of those experiential learning, just having more practice. And we understand, because we had to cut out that part. I mean, that is a very high resource type of training. And so you're welcome to read more about that. And what we are doing now is that we have not given up on that experiential learning opportunities, because I think the best learning for especially adults or children is to practice. And so thankfully, we received additional funding from the Defense Suicide Prevention Office to see if that experiential learning, the simulation component, would go above and beyond the Chaplain's Care Online didactics. So you saw version 1, that was the in-person Chaplain's Care training. Version 2, that was the Chaplain's Care Online for chaplains from all service branches. And now we're going into version 3. It's been about a year that we're planning and preparing. And so we're keeping the Chaplain's Care Online didactics. We're actually updating right now for chaplains, for Air Force chaplains, Army chaplains, and just kind of like doing overall update. And we want to then have chaplains assigned to different group, one out of these 3 different groups. One group of chaplain will receive the in-person simulation practices here at Uniformed Services University and go through group discussions and reflection exercises together for a week. And then another group of chaplains will do it all online over Zoom. And then for the third group, they will only receive the Chaplain's Care Online, but all of them will be assessing the pre and post competency by video recording their simulated encounters with service members. And then we plan to collect the same data on the military chaplain's knowledge, skills, and attitude on suicide intervention. We also have plans to have 1 month qualitative interviews to see how they're applying the intervention skills. And we also have a 3-month follow-up planned. And so for 2015, we were planning to recruit our Air Force chaplains in April, and we're also in communication with Army and Navy Chief of Chaplains to have further recruitment. We're expecting about 200 military chaplains total for this evaluation. So now I'd like to transition over to a project that is near and dear to my heart, and it is a suicide outreach partnership with the Korean American community. And I think with the interest of time, I'm going to go over it really quickly. There's limited English proficiency among Korean older adults, and also there's least reported psychosocial support. There's much of a social disconnection reported among the older adults. And the suicide rates among Koreans are pretty startling. I know last Psychiatry Grand Round, you talked about the rate of suicide in Guyana, and which is really high. Among Koreans, out of the more economically developed countries as part of the Organization for Economic Development, they have 28 out of 100,000 suicide rate in South Korea. But older adults in South Korea has like really high suicide rate. It's close to 80 among men and then 58 among women. And as they immigrate to America, they still hold pretty high rates of suicide. Korean older adult men has higher suicide rate than white older adult men who are known to have the highest suicide rate among all racial ethnic categories. And Korean American women have doubling of the suicide rate among white American older adult females. And so we have seen that there is 15% of suicidal thoughts in the past 2 weeks among the memory and aging study that Dr. Ho-Chang Lee was a PI for about a decade ago. And some of the common reasons that they're underusing mental health services is because, and the main reason is that there's a lack of linguistically and culturally competent services. Yet Korean church can be an avenue for social connection. And the religious leaders in the Korean churches really take it as their responsibility to take care of the well-being, emotional well-being of their congregation members. And they recognize that it is the second greatest problem within the church, second only to marital conflicts. And they talk about their desire to learn their counseling skills. And so thanks to the pilot funding from this department, we're starting a study to culturally adapt a suicide prevention outreach program that was developed by faith leaders for the faith communities to respond to the issues of desperations and despairs related to suicide, to build hope, to bring more of a suicide-safe culture, to have conversations about these issues and build social connections and suicide-related knowledge. So we want to bring this to the Korean American faith community. And first aim is to gather information from the Korean older adults, faith community members. And then second is to integrate the information gathered into the preliminary adaptive version of Soul Shop. So we have plans to hold focus groups and interviews to understand the Korean older adults' understanding of the pathways to suicide and how social connection and religious beliefs and faith leaders play in the role in that, and as well as their help seeking. And I'm thankful to have met Reverend and Dr. Jinsei Kim, who is an ordained pastor and a clinical psychologist who will be attending the Soul Shop Train to Trainer course in Little Rock, Arkansas with me in March. We'll be translating that Soul Shop and adapting Soul Shop with the information that we have gathered, along with the Community Advisory Board. And I'm fortunate to have connections with the Korean American Council for Churches in Virginia area. We met with our Governor Jason Miyares together. And the end of it will be usability testing to have Korean older adults think out loud, respond, to tell us if there are certain things that they haven't understood, that are having a hard time understanding that we need to revise. So I think I summarized our takeaways already in the past. And so social engagement for military chaplain is super important. We know that chaplain's intervention skills training could be feasible, acceptable, and could increase the suicide intervention knowledge, skills, and competencies. And we're excited to start the Soul Shop cultural adaptation for the Korean American churches. And some of the next step is that we're scaling up chaplain's care to other military branches. We would like to also try to seek opportunities to make this type of suicide intervention training available for civilian faith leaders. And I would love to explore more opportunities to religiously integrate evidence-based interventions for different populations, like engaged coaching. We'll talk more about that later tonight, about how this could be useful for the Korean American older adults. And so now that I have a privilege to speak to a room full of psychiatrists or psychiatrist-related professionals, I have some questions that I would like to pose to you in closing. So faith leaders are seeking competency and mental health skills. So how much do you integrate religion and spirituality, at least the preference of religion and spirituality among your patients when it comes to caring for them? So here are some of the questions that you can consider. Is faith important to you in this illness? Has faith been important to you at other times in your life? And do you have someone to talk to about religious matters? Would you like to explore religious matters with someone? And I understand that you have a 24/7 chaplaincy service available in this hospital. So I'd love to hear too, like what that collaboration also looks like. So thank you. I think I only have 3 minutes, but I will be happy to take any questions if there's any.
Really intensive and much longer than a typical gatekeeper training. Could you kind of talk about the rationale for that and kind of how it's different from a typical gatekeeper training?
Yeah, thank you for that question. And we wanted to respond to the military chaplain's desire to really go into the suicide intervention, like counseling, especially when somebody has suicidal thoughts and attempts, because many times they're spending time with the service members and not able to, refer them to professional care because of their confidentiality. And so during that, we wanted to equip them well during that 1 week period. Yeah. Thanks. Yes.
I'm appreciating the intensity of that 100% confidentiality. And so I'm wondering if people talk explicitly about how to tolerate the increased risk that it comes with to the chaplains themselves for carrying that load, but also bearing loss that may have happened in the context of that confidentiality.
Thank you so much for that question. And so that's another reason why for chaplains care, we added the professional burnout part. And we know from the civilian faith leaders too, that close to half of them have depression. And so, and the chaplains who tend to really be aware of their needs tend to have more of a community around them with other chaplains, and they usually work as a team as part of the religious support team together. And so there's a religious affairs personnel who are enlisted members and not like the chaplain level officers. And so there's more of that connection. But I think that is a really important point that we're trying to address too, trying to have more of that community where they can mentor each other and support each other too. And so I don't think there's anything structured yet, but it's a good point. We're aware of it. People are doing it individually, but we would like to see more of the concerted effort in building their support system too.
We have one more question. This one's from Zoom. Due to the history of AA and other self-help groups, there is an acceptance of the role of faith and spirituality in substance use treatment. Can you speak to the efforts to collaborate with faith community leaders related to substance use disorders, particularly given rates of increased overdose as a possible cause for mortality?
Yes, yes, definitely. Yeah, I mean, we talk to our faith leaders too, and I think it's usually in our health systems that tend to separate between substance use and mental health issues and even suicide are in a different bracket. And we really don't need to do that when it comes to helping people who are at risk for these deaths of despair. And so I think if in any way possible, if we can collaborate in the AA or substance abuse prevention type of model, I think we need to do it together. I mean, I really see this as an effort of, for suicide prevention, trying to link between the mental health professional researchers and the faith leaders. But there's still a lot of more linkage that needs to be done with substance abuse. And I mean, even different types of domestic abuse type of work too. So the more we can work together in prevention, the better. Yes. Thank you for that question.
I think we'll end on that. So thank you once again.
Thank you all so much. Thank you.